Commissioners, we're about ready to roll, I think.
All right. Well, before we begin, I've got one thing that I wanted to mention this morning. I don't know how many people read the Wichita Eagle editorial today, but I was very concerned with the article that was in there, and I think we need to have some people do, I don't know if it's our legal or who takes care of it, but we need to find out what the details are on the trips that Commissioner Lehman took at expense of the contractor that sold $7 million worth of goods to the county. So that is a significant concern.
All right, Commissioner.
Okay.
We had addressed that, I think, a couple of days ago when the initial article came out, and I think the counselor's office was already looking at it. So I think we're ahead of the game on that.
Okay. Well, I think we need more details. If there is any truth to what's in the newspaper, it casts a bad pall on the entire commission and the Sedgwick County. So I think we need some more details.
All right.
Thank you. And with that, I'm ready.
Commissioners, I passed out to you, and we'll talk about this at the end to let the conversation on health benefits start. But just to give you something to think about until then, is I gave you a list of dates, and specifically I'm concentrating for our BOCC meetings in August. And I just wanted to highlight a couple of things. I know the chairman plans to be gone after budget adoption August 15th through the 29th. But traditionally on August 8th, which is after elections, and also August 22nd, which is the week after budget adoption, we traditionally don't have meetings. But based off the schedule, this could significantly have an effect on how many meetings we have in August. So right now, the 1st and the 15th are setting up to be two that we definitely will have. But the rest of the schedule, I'd like for you to think about that, and at the end of this, if we could talk about what dates you want to have and what dates we should cancel. And with that, I'll kick it to Tom.
All right, very good. Good morning, Chairman, Commissioners. Tom Stolz, Deputy County Manager. And today we're going to have a workshop discussing our pending health and prescription contract, which expires at the end of 2019. So this is kind of the first information session that we are going to have to kind of talk about what we're going to roll into in a year and a half. We're going to provide you with some information today. We have representatives from IMA who we have contracted with to kind of give you a state of health benefits and prescription benefits out in the community. And then we want to also listen to what your concerns are and some of the questions you may have. So we'll be taking notes feverishly as you ask questions and make your requests known. The agenda for today will be run mostly by Heather and IMA. Heather will get up and kind of step you through the timeline of how we're going to work this process between now and January 1 of 2020. We've also recently done, through the communications department, an employee survey that we'd like to share some results with you on. IMA will then get up and introduce themselves, and they'll give you an overview of the market analysis, and then we would entertain questions and comments by you. We're going to try to get all this done in a couple hours. So I know IMA has probably a half hour's worth of presentation, so we want to leave you guys plenty of time at the end to ask questions. So with that, I will turn it over to Heather. She can go through the timeline.
Good morning, Chairman, Commissioners. I'm Heather Porman, the Benefits Manager. I'm going to talk about our project timeline for the next 2 years. Beginning in April and May, as you know, we selected an actuarial broker to partner with us in working through the 2020 health plan design, as well as preparing an RFP for our medical and prescription. Our current contract is up with United Healthcare as of 12/31 of 19. So we will be producing an RFP in August and September to send that out to various medical and prescription carriers. In November and December, we will have an RFP review committee. We're anticipating between 7 to 12 employees here at Sedgwick County within various departments to participate on that committee. In January and February, we will select a medical and prescription provider. In February and March, start the implementation process. That would be the logistics of setting up our internal systems, piecing together communication, plan design options, those types of things. In February and March, we will work with that carrier to start a communication and marketing of the plans for 2020. And in April through October, we'll do a lot of employee education, offering resources and tools to help those employees learn about the new plans. And of course, as always, in October and November of 2019, we will have open enrollment. I want to talk a little bit about the survey that Tom alluded to. We did an employee survey at the end of May. We did that for 2 weeks. We had over 1,000 employees that responded. This was a very high-level survey just to kind of get the perception of employees on our current health plan, and we also asked some open-ended questions on what those employees were looking for going forward. As far as the overall satisfaction of the health care benefit plans of Sedgwick County, 753 were satisfied and 308 of those were unsatisfied. Keep in mind that when I say health care benefit plans, this was strictly for our medical and prescription health plans. Some of the reasons that employees were unsatisfied with the health care plan, the number one was too much out of pocket. In this survey, as well as other surveys we've done over the past few years, employees have expressed an interest in paying less out of their pocket when they actually go to have services and pay more in their paychecks for health care expenses. So this was consistent with what we've seen in the past. The other items were lack of plan options. There were 93 employees that expressed that, and then 51 that had other unsatisfactory reasons. The next question was, how likely would you be to select a high deductible health plan in conjunction with a health savings account or an HSA? 230 employees were likely and 831 were unlikely. I believe that the 831 that were unlikely might be an education issue. We might have a lot of employees that don't understand how these plans actually work, which is why they answered that they would be unlikely to select a plan like this. Changes that employees would like to see in their benefit plans. We had 560 that would like to see more plan options. 390 would like the lower out-of-pocket cost with the higher paycheck deductions. 106 wanted higher out-of-pocket cost with lower paycheck deductions. 357 desired additional coverage, and we had 163 other responses. We had some open-ended questions, so employees provided additional feedback. Keep in mind that some of these comments may be incorrect about what our plan actually covers, but it gives us an idea on where we need to go as far as education on how our current plan works. Again, these were all comments from employees on the medical and prescription plan. Some of the things they would like to see is gym memberships, the bariatric or weight loss surgery, better vision coverage, and LASIK coverage was specifically mentioned. Improved pharmacy and lab coverage, better dental coverage, better mental health coverage, chiropractic care, fertility coverage, and then there were several pharmaceutical issues that were listed. Some of the comments were that prescriptions under United Healthcare are mail order only, the brand of the medication is often changed without asking, and that the plan does not allow automatic refill. Did you guys have any questions on the survey information or the project timeline before we moved on?
Any questions? Commissioner Howell.
Thank you, Mr. Chairman. Back to the back to the slide that talked about the high deductible health savings plan, likely and unlikely. What did you provide any information exactly what that would be and how that would work, and so that they had that knowledge before they answered the question, so they understood the benefit potentially to them?
We did not on this question. So that's why I believe it's attributed to a lack of education.
Okay, thank you.
And I think, Commissioner, that's something we need to look at going forward, that we need to provide some education.
I think if you take the same pool of people and you spend a lot of time talking about how this might be a benefit to them, they might change their opinion. Mm-hmm. We ought to do that exercise at some point because we need that data.
Good.
All right, thank you.
Okay. Next, I'll move on. We do have 3 health and prescription carriers that are represented today. I'll just do a brief introduction. They won't actually be speaking, but they are here to listen to IMA's presentation and your feedback as well. We have Drew Burns from Aetna, Bernardo Cruz and Janet McMurray from Blue Cross and Blue Shield, and Marion Govro is with United Healthcare and Optum, and of course United Healthcare and Optum is our current medical and prescription provider. I'll turn it over next to IMA. We have Diane Thornton and Rex Wilcox with us, and they'll spend the next 30 to 45 minutes talking about emerging trends in our healthcare.
Thank you all for investing time in today's workshop. We want you to see IMA as your partner and resource for questions, for answers, for research you can delegate to us in order to help you all make an informed decision of the direction you would like to go with this RFP and the benefits for county employees. There's a little bit on the screen about IMA. And then just a little bit here about Rex and my background. I'm really here to help facilitate, make sure that we're engaging in all of the levels of resource that we can provide as IMA for the RFP and the project that you've selected us for. Rex Wilcox is here today as one of our team members who has some expertise in this area, and he will be the one facilitating the majority of this conversation today. We appreciate the time, the opportunity, really, and again, want you to view us as a resource. So please ask questions. We do want this to be interactive. It's your meeting to learn what you want to learn about benefits going on and trends nationally as well as within the marketplace, and most importantly, what you want to engage and implement here at Sedgwick County. I'm going to turn it over to Rex, I think, at this point. Again, we're not here to promote a product, a plan design, a service. We're here to answer any of the questions you may have and then take that dialogue forward as we develop the RFP with your team. Thanks again, and I'll turn it over to Rex.
Thank
you. Good morning, and thank you for having us. So we've been asked to come and provide some high-level insight into where we see some growing trends within the healthcare sector in terms of both how healthcare is being delivered as well as how it's being integrated with employer-sponsored benefit plans. So I have a handful of slides that are high-level. I'll speak to greater detail, and as Diane mentioned, by all means, please ask questions at will, as I'd prefer this be a little bit more of a discussion than a talking head standing here staring at you. One trend we've seen growing substantially in recent years, and you actually have a very strong presence for it here in the city of Wichita and Sedgwick County, is direct primary care. Direct primary care is a membership-based access to a primary care physician. It functions outside of a normal insurance plan. So in this arrangement, it's available to direct to consumer, so to speak. So I can go off the street outside of my insurance plan and pay a monthly membership fee to have access to my physician. My employer can pay for that access as well. In essence, the way this functions is, if you're familiar with concierge medicine of 20 years ago, it's an evolution of that. Whereas concierge medicine 20 years ago was you paid, in essence, a retainer fee to have enhanced access to your primary care physician. In that arrangement, you would pay whatever the retainer was. Maybe it was a monthly fee, maybe it was an annual fee. And then every time you interacted with that physician, your physician would still file a claim and bill your insurance carrier. In direct primary care, they've completely stepped aside from the insurance market. So they don't contract, most do not contract with insurance carriers. It is, in essence, a cash business. And so in this arrangement, the individual or an employer pays a monthly membership fee. Think of it just like your gym membership. By paying that monthly membership fee, that patient, that individual, or maybe a family has access to that physician 24 hours a day, 7 days a week, 365 days a year. They have access to that physician by phone, by text, by email, and many incorporate video consultations as well. Some of the benefits of this model. By having increased access, now you have the potential, and we see results show that this holds true, that now rather than your employee, their family member, rushing to the ER at 9 o'clock at night because their two young boys decided to play with a paint can, and one swung it and cracked the other one's head open. Rather than rushing to the ER to have that addressed, looked at, racking up probably a $1,000 bill for that, mainly for it to be looked at, cleaned up, and probably sutured or stapled up. Now you can call your primary care physician. He can say, hey, send me a picture of it. Take a picture with your phone and send it to me. Looks at it. Okay, great. I'll meet you in the clinic in 20 minutes. Meets the family there, meets mom, the child, looks at it, staples it up, cleans it up, sends them home. There's no out-of-pocket cost to that individual. That membership fee pays roughly 95% of all of their primary care. So the cost for the visit, the cost for the cleaning, maybe antibiotic injection, suture, staples, whatever that treatment entails, there's no additional cost. That is incorporated into that monthly membership fee. And so they go home. The plan hasn't incurred, or the employer hasn't incurred any additional cost. Again, it's captured all in that monthly membership fee. And the member didn't incur any additional cost. There's no copay. We see this program being very effective even beyond just the standard approach to primary care. In addition to being able to avoid unnecessary and very costly emergency room visits, you can also save on urgent care as well, which tend to be higher in cost. But you can also save further because in the fee-for-service world, where a physician is seeing a patient and they have to see 30-plus patients a day in order to keep the lights on under the normal fee-for-service model in an insurance contract and insurance relationship. Now they have a smaller patient panel. So instead of that primary care physician you're seeing in a direct primary care arrangement, rather than that physician having 2,500 or 3,000 patients that are attributed to them, in direct primary care they have 600, maybe 1,000. So now rather than spending the industry average, national average of 8 minutes face-to-face with a patient, they're spending 30 to 45. That gives them the ability to practice at their full scope of their training as a primary care physician. So they can actually address that individual's diabetes, hypertension, many of the comorbidities that individual could have that commonly are referred out to specialists because that primary care physician just doesn't have time to really address those needs in that arrangement where they've got 5 to 10 patients sitting in the waiting room for them. So you can see now if we're avoiding ER costs, we're avoiding urgent care costs, not all, but many. If we're avoiding unnecessary referrals out to specialists, where now you're looking at maybe $350 to $400 for that visit to a specialist, plus the member's responsibility. Again, now that's all being wrapped into that monthly membership fee. Okay. Another area, and this is not necessarily new, but we're seeing continued evolution in the space, is telemedicine. Telemedicine has been around for a number of years now. It's becoming somewhat of a staple or mainstay. Most of the insurance carriers are providing one or multiple services to insured members. But again, this is access to a form of primary care. This is not by any means the same as direct primary care. This is intended to address episodic or acute needs. So the fever, the stomach ache, the sinus infection, bladder infection. Again, great resource to avoid costly, unnecessary utilization of the ER. To put it in perspective, the last numbers I could find for Sedgwick County, the average ER cost for your plan in 2016, a little outdated, but was the number I could access, was about $1,400 for an average cost of an ER visit. When you compare that to telemedicine, I believe your plan cost is about $40. Again, it can't treat everything that might need to go to the ER. It's not going to address a broken arm. It can't necessarily address that laceration of the scalp that I used earlier as the example with direct primary care. But it can address a number. I think I've seen roughly 50 to 60 different diagnostic codes that are commonly addressed that very commonly present to the emergency room or urgent care, but could be addressed through telemedicine. Telemedicine is leveraging technology where the member has access by phone. They can even use an app on their smartphone and actually do a video consult with a physician. When they have a need, they submit a request, and usually somewhere between 5 to 15 minutes, depending on who the telemedicine provider is, you'll have that consult with that physician. They'll provide insight into what they believe the diagnosis is. They can even prescribe a medication, have it sent to your preferred pharmacy of choice as closest to your home. They can even, if you're traveling and you're in Arkansas, Florida, California, pick your state, that individual can still utilize the service. When you first are submitting your request for the medical consult, they will request what state are you calling in, or will you be receiving the call in, so they can ensure that a board-certified physician for the state, board-licensed physician for the state you are calling from is the one responding to your request for care. Where we're seeing some further evolution of this, I hate to call it this, but in all honesty, telemedicine is almost becoming a commodity. But where we're seeing an evolution of this, we've been leveraging the telephonic and video access for a number of years now, and now there's new technology that is coming to the market using artificial intelligence and chatbot technology, where through natural language recognition, you initiate your consult with the telemedicine provider vendor, and it's using a chatbot to recognize, to ask quality metrics around safety data, accidents, fatalities, infection rates, and so forth. These programs really function in one of two ways. One, it's looking at and comparing what are the costs within your network, within the network contracted reimbursement rates with those providers, and what those costs are through your plan. In other cases, the programs are developed to actually show you, in essence, a cash price. So on a high deductible health plan, you're responsible for first dollar cost. Hopefully you funded, or your employer has funded that health savings account with some money to help pay for those first dollar costs. Now you can actually consider, in essence, the off the street or cash prices. So for laboratory work, imaging, CTs, MRIs, and so forth, x-rays even. In some cases, minor surgical procedures that are elective. And in doing so, then you can actually look for where you can stretch your health savings account dollars to the greatest extent. So rather than going and paying $500 by running it through the plan on a high deductible plan and paying $500 for that MRI, maybe you pay the cash price. It doesn't run through your plan, but through these tools you can identify, well, I can go and get the same service for $150 here. So now I can extend the dollars in my health savings account further. But it's not quite that easy, though, because then they're also making a decision that $150 is not counting toward their deductible because they didn't run it through their health plan. Does that make sense? Okay. So these cost transparency tools are available. It's giving those on a high health savings account, high deductible plan, the resources to begin shopping for their care so they can truly act like a consumer. The challenge is it's still very confusing to them. The information is there, but they don't fully understand it because this is a complicated world. Yes?
Commissioner Ranzo.
So going back to the statement that if they go through this cost transparency, it doesn't apply to the deductible. Why not?
So they have the choice. So if they choose to pay a cash price somewhere, that is outside of a network arrangement. That is a cash price off the street. So again, a cost transparency tools function in one of two ways. So one, when you look at it, you're shopping and you're looking at, this MRI facility will provide the same MRI study for $500, and this one will provide it for $300. But that's considering my network, my plan, and what that plan cost is. I can still use my health savings dollars to pay for that. Other arrangements, other cost transparency tools provide you costs for services outside of your plan. In essence, a cash price off the street. So if you're paying for it if you run it through your plan, still using your HSA dollars, that money counts towards your deductible. If you pay for it purely out of your HSA and not considering your plan, so you're not considering network discounts, you're purely paying for, in essence, an out-of-network service on a cash basis, that would not count towards it.
Well, why is that?
That is just the way that
Is that dictated by the plan or by law?
It's law. There's a lot of
That's federal law, state law.
I think federal is.
I think it depends on how the carrier's contract is written, correct?
That will factor in as well, and in some cases you can actually submit and request for that money to count towards the deductible. The plan member can submit that for that to be considered, and then that's going to come down from one carrier to another in terms of how the plan is written.
We could work that out if we decide to go there. I mean, if we give money,
absolutely.
if we give money to employees for HSA and a high deductible, we would want it to. We want them to find the lowest price and still have that money count towards their deductible. I would think.
Right.
Okay.
Right.
Thank you.
Okay. Care advocacy services. So these are services that sometimes will incorporate some cost transparency tools or resources, but really this is providing, in essence, a member advocate, if you want to call it that, someone who can provide answers and help that plan member understand their plan, what is their coverage, where are they relative to meeting their deductible, even helping them through enrollment and understanding what might be the best plan option for them if they have multiple plans to choose from, how they might consider best be served in terms of their funding to their health savings account. They can even help in providing an in-network provider that is within a relative distance, say radius-wise. So these are services that, again, some carriers will provide as well, or you can contract third party to deliver these services. And again, in the space where these pair well with a new plan offering, especially with a high deductible health plan and a health savings account that is very new, very foreign to a population, to help them to better understand and leverage that plan to the best of their ability so the plan works for them. So understanding, again, where they are relative to their deductible, where in-network providers. And again, many of these services will also incorporate or link very closely to various cost transparency resources. So not only are you looking for an in-network provider, but they're also going to provide you maybe 2 or 3 options of an in-network provider for that service that you have a need for. And in doing so, they're providing some cost comparisons for that provider as well. These services are able to be provided by telephone, sometimes email, and we're even seeing some of that chatbot technology I referenced earlier with regard to telemedicine. We're seeing that being leveraged through these services as well. Many of them are being delivered via a mobile phone app, where you actually have access to your plan documents, your benefit card, as well as even you can link right into your telemedicine service right there in that mobile app. So it serves a little bit as a one-stop shop for some of the services tied to your health plan. And in many cases, they're also incorporating some cost transparency tools around pharmacy costs, which could apply either specific to the plan or on a cash basis outside of the plan. PBM on their formulary, they'll prefer Novolog versus Humalog, 2 different diabetes medications, virtually the same medication, just different manufacturers, and that PBM will only allow Novolog to be filled versus Humalog, and in doing so, the PBM receives a rebate for that. Depending on then the arrangement, the plan, the employer-sponsored plan has with that PBM or through the carrier, they can receive some or all of those rebates. And in many cases, the rebates are very, very attractive. They look very impressive on a spreadsheet when you're comparing one PBM to another. The challenge is that in many cases, you can get a much higher rebate, but in order to do so, you have to acquire or pay for a much higher cost drug. So you can chase an $8,000 rebate on a $32,000 drug, or you can chase a $5,000 rebate on a $25,000 drug. So the net on that 32 is a $24,000 cost on that drug, 32 minus the 8,000 in rebates, versus going for preferring the $25,000 drug with the $5,000 rebate, lower list price for the drug, net price after rebates is $20,000. And so understanding and knowing how the system is built and how the formulary is built to encourage rebates and what the net drug cost is very critical to managing the plan and encouraging appropriate drug utilization so that you're maximizing rebates without driving cost on the drug up. And with that, that's all I have. So I welcome any questions that you gentlemen have.
Do we have any questions at all? Commissioner Ranzo.
Yeah, on the high deductible and health savings account and direct patient care, is there a way to pair those up?
There is. And so this is a very gray area from a IRS federal standpoint in terms of how the HSA dollars can be utilized. We retain external ERISA counsel to provide us guidance in specific areas such as this. The guidance we've received from that external counsel is that an employer can pay the monthly membership fee for those members on a high deductible health plan who have an HSA. Where it gets stickier, and again, there's a lot of gray area here, and there's a lot of movement in DC to try to rewrite some of these regs to clear up this gray area. But if the employer is going to pay for that membership fee, the employer cannot also contribute or fund the HSA on behalf of that member or that employee.
Okay, so that actually helps segue to my next question that I want to throw out there for you and anyone else. I don't know who all is going to speak, but I'm interested in knowing as we go through this process if there's any legislation changes that the state or federal level or regulation changes that might be beneficial to us and others as far as expanding options and lowering costs that we need to be aware of. I think we'd like to know so that we can address that with our own, like I said, whether it's a state or federal. Okay, we want to know about that.
Yeah.
And I'd like to be active in that myself because I think we have currently. I think with the current administration, I mean, we might be able to seize the opportunity to do some things.
It would have to be at the federal level, and we do provide fairly regular governmental compliance regulatory updates, and I believe Heather should be receiving those. But there is, as I mentioned, there is definitely an effort in Washington, D.C. to clarify some of the regulations around how HSA dollars can be used, how HSA funds can be funded, and so forth, to clear up some of the gray that exists today.
Well, then maybe we need some fact sheets or a white paper or something for commissioners, and I'd like something that I can take to Congressman Estes and say, hey, here's some things that we think would help us as we move forward in the next year and a half. And, they need to hear from us. And I'm sure, probably not just us. There's lots of employers that would probably benefit for this. But I guess we need to be educated on it so that we can educate and keep pushing. And at some point, I've also heard that the state of Kansas passed a law that would authorize us to do some alternatives to the ACA or whatever, but we just have to ask for a waiver at the state level. If anyone has any insight on that, I'd like to hear about that at some point, if that's not here today. But if we need to be encouraging the state to apply for some sort of waiver that would increase options throughout the state with respect to health plans, I guess is what I'm getting at. You hear rumors from time to time, and you hear that, well, it's the law that stops this, that, and other. Well, then let's see if we can get something done. I think we should take advantage of that if the opportunity arises. So,
Thank you. Commissioner Howell?
Thank you, Mr. Chairman. Just one thing you did not talk about today, maybe it's not an option, I don't know, but there's another plan I would call the MediShare type plan where it's a shared cost between employees that are receiving. Again, it's a managed program, but for qualified benefits that are you consumed, if you will, by the employees, that those costs would be shared by all those in the program. Is that something that we have as an option as well?
So this is really there. I would say there's probably too many pitfalls or concerns around how that is managed, because it's not, those Medishare plans are not necessarily specific to an employer. They're broader than that. So a group would have, employees could join, but those monies are shared amongst a much larger population. The challenge is that there's no regulatory body managing those from even, say, a solvency standpoint. So there's no guarantee that there's going to be enough funds available within that design and in that program to address, say, you had an uncharacteristically high number of catastrophic claims in one time period. They may not be able to completely support that.
Well, but those plans have been around for a while, and they are working. And so the larger the pool, the more average those costs will get. There's going to be, every month is going to be large expenses in that pool, but spread that out. I mean, these things are working, so.
They are working, but I think from an employer standpoint, there's a greater risk there in terms of how it would be incorporated, and that's then what, in terms of how it's meeting the minimal requirements from what is provided health plan standpoint to employees.
Well, let's talk about United Healthcare for just a minute. We've been in a plan. Correct me if I'm wrong. Someone please tell me if I'm wrong. But we are essentially self-insured. We pay United Healthcare to manage our system, but whatever those costs come in, we pay the costs. So we're essentially paying them a management fee, and whatever the costs are to the county, we pay that. So essentially, that's a similar challenge to the county.
Yes.
Am I right in saying that?
Yes, but there's different protections on the back end where you have stop loss in place, and you have various other protections from a financial standpoint that you don't necessarily have with those ministry sharing programs.
Okay. Well, anyway, I guess I'm personally interested in that. And again, back to the HSAs for a few minutes. My opinion of HSAs is that the employee has a lot of options on where he can join in terms of. In other words, you might have several employees that might have, employee might want like a certain level of deductible and certain level of cost, and somebody else might want something different. But are there going to be, would there potentially be options within the HSA program that employees could pick a number of different providers that they can select from? Or
so again, that comes down to decisions that are going to be made by the county in terms of what type of plan offerings to make available. But yes, you could have multiple plan designs that are all high deductible health plan with HSAs, meaning various deductible levels, as well as I believe you can even vary the HSA contribution between the various plans as well.
So I guess I think the reimbursement accounts have been around a long time. I think they pair very well with like PPOs and that type of thing. That's not a problem. They've been around probably a couple of decades, I guess. Anyway, quite a long time. But the HSA, in my opinion, is different because it gets to the idea of ownership. In other words, the employee has an account. We provide money to the account, and they may provide money to the account that may be tax-free. So there's money pouring into the account that they have ownership, and if they leave, that money goes with them. Is that the understanding that you have on HSA?
Yes.
Okay. The ownership then, because I want to make sure that the education part of this is really important, because for them to think, oh, I got to come up with $12,000 for deductible this year, that sounds very scary. But to put it in perspective, I think my family and I used to have insurance through Boeing and then other aircraft companies around town. I think the average cost for a family's worth of insurance per year at that time, this has been a number of years now, was close to $20,000 a year. And I think the county's average cost is, someone correct me, but I think it's been around $17,000 for a family. And so if you think about pouring money into an account so they have decisions on their health care options, health care benefits, things that they want to, not, we're talking about preventative care, we're talking about things that are on top of that. They have some skin in the game, but it's covered through the account. So unless they pour through that entire account and spend completely through it, their out-of-pocket could go to zero. For many employees, it would be zero. In fact, they would have a positive account balance most of the time, and when they leave the company, or leave the county in this case, they would take it with them. So to me, there's a lot of benefits. One thing that's frustrating to me is we have, I think, to be very good insurance, but we rarely actually get any benefit from the insurance because we're paying virtually everything out of pocket. Our deductibles and copays are high enough. Other than preventative care, we're actually funding most of the things that are outside of preventative care. We're paying ourselves because our deductibles with the county plan we have right now, the deductibles are high enough that we're doing that virtually completely out of pocket, out of salary. There is no account to cover those costs. That's my problem with this. And so we continue to add 5% or 8% cost per year. Costs are going up and up and up, and the employees don't seem to have any skin in the game. That's the word you used, right? Mm-hmm. If they have an account that's got money in it, they can make a decision: do I want this service or I don't want this service? If they want the service, they pay it out of the account. To me, that's the advantage of the HSA. Now, the reimbursement account, that is something that it does not roll over at the end of each year. If they don't use it, they lose it. Correct?
Correct. And
that's a little interesting twist on that, if I understand correctly. When they opt, let's say, for $4,000 to go into a reimbursement account, that money's available on day one. It's covered by the employer. If they use all $4,000 in the first month of the calendar year and then they leave the company for whatever reason, they don't have to pay the money back, even though they're supposed to pay that out of their paychecks over the year. At the end of the year, if they go the entire year and they use all the money, we break even. We didn't spend any money on their behalf. They covered 100% of the cost. But there are some caveats. If they don't use it, they lose it. And if they use all the money, let's say earlier in the calendar year, and then they, for some reason, terminate their employment, there's no payback. It's just a cost to the employer. We actually have to pay that full cost of the reimbursement. So it's an interesting caveat on the reimbursement. So again, it's interesting, but it really doesn't really, I don't think, impacts most of the things we're talking about today, because it's more of a traditional tool. It's a tax benefit, but it doesn't really get us into these other options. I like Commissioner Ranzoff's question. The fact that pairing some of these things together is very interesting to me. My biggest question probably would be for lots of companies out there, and I'm sure you've dealt with lots of large companies that have benefit packages. Transitioning large numbers of employees from, I would say, traditional PPO or whatever HMO or whatever type of program they might have to some of these more 21st century technology-based options. Have you had good success in terms of, I think it's scary on the front end, but down the road people appreciate them and like them? And what are the problems you're seeing with the transition?
The transition is very challenging because there's a tremendous amount of education that is required so that those employees and their family members understand how this new type of health plan, so using the example, going from a PPO to a high deductible health plan with HSA, how it functions differently and how you can leverage the HSA dollars and being responsible for more of the first dollar cost. So there's a tremendous amount of education, and some employers just try to focus their education during open enrollment. Well, unfortunately, that's probably the worst time to try to educate your employees, because all they're focused on is what plan options do they have, what's their monthly check deduction going to be from a premium standpoint. They're focused on the financial side of it during open enrollment, not the inner workings, so to speak, and how that affects them. And it doesn't make much of a difference to them necessarily at that time, because they're of the mindset, well, I'll worry about it when something pops up. Well, how likely are they to figure it out when they have that ER visit or that surgery that they need? So it's not just even education before open enrollment, it's ongoing education throughout, so that there are constant reminders, so that when somebody does finally tap into and need their insurance coverage, they have an understanding and they know where to find the information. And that's where, again, we talked about like those care advocacy programs, where if they know, they can pick up the phone and ask a care advocate, a member advocate, where do I go, what's my deductible, what's my cost going to be, where can I get a lower priced MRI, those types of things can be very, very useful and helpful for them. Yeah, and as well as even looking for various tools to reduce the cost through various programs available to offset the cost of those high specialty medications. Did you have something you want to add, Diane?
I think one of the biggest transitions when you roll out a high deductible health plan, if you have an employee that has one of those really expensive specialty medications, they need to pay for that 100% at the pharmacy. With a hospital bill, they can work out a payment plan if they aren't financially prepared, but at the pharmacy, they can't obtain that drug unless they pay for it 100%. So again, just an education thing. They're very good plans. Education's very key to making it work. They're not for everyone. I would say the vast majority of employers that that we see offer it as an option so that employees can pick and choose which option they want to go with. So lots of good choices. I think you're asking great questions on looking for some options and giving employees some choice. But we do occasionally get calls at our office from an employer who has an employee standing at the pharmacy saying, my employee has to pick up a $2,000 drug and they don't have the cash or the funds or the credit card to make that work. So that's probably another pitfall of the plan, but again, not meaning that should jade your decision on whether you offer them as an option or not.
What percentage of the population has very high prescription drugs that they utilize? I mean, I'd like to apply the same percentage to the county, for example. I have no idea if it's 1% of the employees or the population, or if it's something higher than that.
We'd have to look back at your year-end report from 2017, but on average, you're looking at in the ballpark of 1 to 3% of plan members are utilizing specialty medications, those higher cost drugs.
Is it possible to separate them out for more of a grandfather type? I mean, again, creating options for those that are going through a terminal illness, let's just say, or something really very, very serious. This would be very hard for them to envision transitioning to something like this. But for generally healthy employees they're doing fairly well, I think these are very good, because I think for most employees we would see the way to lower the cost for the employees and the employer both. I think everybody benefits, I believe. But there's going to be a few people in the organization that this is not going to work. So what do we do with them in terms of do we have the chance to give them something unique and special to manage them?
It would be providing various plan options that some might be only more appealing to those with much higher utilization or much higher cost. There are also various programs available through different vendors and providers to help reduce some of that cost through alternative means in the specific space of drug utilization. Leveraging money that's made available even through the drug manufacturers to reduce the cost to the member for those medications.
And perhaps it's premature, but I'll just state here that in trying to transition to a high deductible plan, should that be the direction we're headed in some way, I would like to see the employer, and again, in this case the county, provide, if you will, some transition assistance to get that account funded for most employees. And so I can imagine us on the first year partnering at a higher rate to get that account funded, so that no one's going to see a significant cost to them that first year. That transition, I think, needs a little bit of help from the county to get started. But second thing, I just want to wrap this up. I'll stop with my questions. But I just think that to anybody who might be listening, again, I don't think we're trying to be cheap, but I just think that the point is that healthcare continues to go up for the employee. If we don't provide some other options, it's just going to get more and more expensive for everyone, including the employer and the employee both. And I think it's time for us to look at other options. And this is ideally the goal here is to stop the inflation on cost of insurance for us, but also especially for the employee. Find ways to lower, even maybe eliminate the out-of-pocket costs, and provide extremely good health insurance options and benefits. I think it's possible, but we have to insert some of these new ideas into the process. So that's the goal. That's what I'm hoping we can accomplish here. Thank you, Chairman.
Thank you. Commissioner Ranzo.
Yeah, on prescription drugs and direct patient care, we've heard from the people here locally that do direct patient care, and they're stating, they dispense medications and are able to pass on, according to them, significant, huge, even above the generic cost. Maybe a year's worth of medications for the price of what it would normally be for one copay. Is that accurate, valid?
Yes, it is. So in the direct primary care arrangement, most direct primary care practices do choose to dispense a limited formulary of medications, usually primarily, if not all, generic medications, and they're usually in the ballpark of about 150, maybe 180 medications that they dispense. They are able to acquire the drug directly from the wholesalers, which eliminates some of the additional middlemen in the normal chain of delivering prescription drugs. And through that, they're able to eliminate a lot of the fat, in essence, the added cost to those drugs. And so you are correct. We've done some analysis on costs for drugs, and we're seeing well above $100 average savings. So we looked at, I think, about 55 of the most commonly prescribed drugs or dispensed drugs from a primary care practice. And when you compare that to the average purchase price through a plan, we were seeing on average over $100 in savings per drug.
Per drug, is that per month, per year?
That would be on a per month basis.
$100 savings per month, per year. I mean,
And it's going
$100 per drug per month.
Yeah,
savings.
and you know, you're going to have outliers where it's a $400 savings,
but
and
it's
others
an average.
where it's but keep in mind, I mean, it's a very very small number of medications that they're dispensing. They're usually for chronic conditions, maintenance medications. Potential concern, but that's something that I think both practices are very open to discussions around how to manage. And in all reality, it's a very foreign concept. So unless the county were to put in some type of plan where, in essence, that was the form of primary care made available, your early adoption rates would probably be somewhat low.
Again, I think that's a reason why you'd want to offer choice. There may be individuals who don't want to switch doctors because they like the relationship they currently have with their primary care physician, but there may be those who don't have a doctor identified, would welcome the model of knowing they could call that doctor 24/7. So again, we've heard from Heather and Tom that choice is something that's important to you all, and I think those are great things to consider. Some of these models, just like the account-based designs, they'll be appropriate for some, not appropriate for others, but in giving people choice, that's definitely a trend we're seeing with employers, so that employees can decide where they want to spend their dollars, how they want to access care, and you're providing a quality package, giving them choice, and quality is defined by the employee in terms of their own specific needs and financial barriers or availability of dollars to fund those higher costs.
Good. I appreciate it. I don't see any other comments, questions right now from any of the commissioners. I agree that we probably ought to offer choice. I hope that if we do offer choice that we have the ability to teach the folks what would be the best choice for them somehow. I know that, for example, doesn't deal with this one, but our folks over at the Extension Center do a great job of advising people that are going to go on to Medicare on what are different options they have. So we're going to have to do something similar if we add a number of options for the people in our employee. So thank you for that update. I appreciate it. I don't see any other questions.
All right, thank you.
Thank you. What do we have next?
Commissioners, as indicated in the beginning, the only thing next is just to talk about the August BOCC meetings, just to kind of start nailing down the schedule. Right now, the 1st and the 15th are really the ones that are locked in. Is there any desire to have a meeting any other date in that month?
Hey, any comments from any of the commissioners? One of the concerns I have, obviously, is my wife and I's 50th wedding anniversary is going to be celebrated at that time, and we're going to be departing on the 15th as soon as we're able to pass the budget and get on an airplane, and we won't be back until the 29th. I know for a fact we are going to be down to 4 commissioners, maybe less than that if anyone else wants to take vacation during that period of time. So, again, I know we've got some very important business to conduct. It's always nice when we have 5 commissioners, because if you don't have at least an odd number, there's a chance of a tie vote. The other concern, I understand why we don't want a meeting. We haven't in the past scheduled a meeting the day after primary. I don't know if that precludes us from having one 2 days after the primary, though. We might be able to slide it to the 9th or something like that if we need to have make sure that we have enough meetings during the month to be able to conduct business. So what are the other commissioners' concerns? Commissioner Unruh?
Well, my thought is that
having a 3-week hiatus from taking care of county business seems like a long time. It seems like we could have a meeting on the 29th with just 4 commissioners, and we could take care of whatever consent agenda items and that sort of thing is necessary. But I don't think this. Probably we've already had a precedent where we've taken 2 off in a row. But I mean, I would, if we're here on the 1st and we're here on the 15th, it would seem like perhaps a August 29th meeting to kind of clean up any end-of-month stuff or any consent agenda items. And 4 commissioners can certainly handle. I mean, we don't have to have anything contentious. I mean, we could. I mean, we were going to vote on what color tie the manager should wear, but that's about as. We could keep it in that category, maybe.
Okay. Or I am back on the 29th, so we could always have one the 30th too. I don't know if Wednesdays are sacrosanct. That we can't have one on another day or not. But anyway, Commissioner Ranshow.
I think I'm with Dave. I mean, it seems like traditionally a lot of staff take vacation off, and it really slows down after budget. That I don't know, is there? I'm fine with having one on the 29th. I think I'd be fine with missing a few weeks because it seems like historically, if I remember right, there's just not a whole lot to do. But so I'm kind of flexible there.
So you want one on the 29th? Is that what you're saying?
Well, let's schedule one for the 29th. If we get to that point, we've only got 4, and the manager can look and say, well, there's nothing there that we can't put off for another week, then we could always make that on the fly.
Yeah, that's what I think.
Okay.
Very good. All right. So we'll open up the possibility of having one on the 29th. And I know you'll miss me, but I won't miss you. Hey,
All right,
Mr.
that's
Manager, do you
all.
have anything else?
That's all I have, Commissioners.
Good. Any of the commissioners have anything else that they'd like to add? Any of our electeds in the back of the room have anything that they'd like to add? Anyone else in the room have anything? Seeing nothing, I guess we're adjourned. Thank you all.